Hey, everybody. So, this is the final episode of First Bite for the year. And then after this, we're taking off January because we've got some pretty exciting, very large projects that speech therapy PD is taking knocking out of the ballpark. I'm not quite sure how to describe how amazing these are. So stay tuned for big announcements in January. And if you are a dual certified SLP, as an SLP as well as a CLC, this is for you, baby. Yeah, so that's exciting. But today's guest, I am very humbled and excited. We have Doctors Rachel, Tyrone, and 2B Torrey Robinson. And I want to make sure I get their program correct. It's the University of Mississippi Medical Center. And they are actually on to talk about a topic that could on the surface be kind of confusing. So it's about population health versus public health versus social determinants of health. And each one of those terms has their own respective definition, but there is overlap, especially when it comes for the speech pathologist that's working with the human world. And we want to seek to understand barriers that we may not know about, how diseases and disorders can manifest, and how and what we can do in order to process improve. How can we serve? Where can we tithe? Where can we volunteer to build stronger communities? And y'all, I have to be honest. Excuse you, Goose Danger. Goose Danger's coughing in the background. This year, community was on my heart, and especially here in my immediate Shenandoah Valley area. And I'm sticking with that theme for 2026 because I have been very humbled by the good works that we have poured into the immediate community here and seeing the outgrowth. I am overcome with joy and awe at how the community efforts here locally are transforming. So we're going to have big community building events at a state and national level in May. And it's just, this episode feels like the first perfect episode to close out First Bite, to prep for all of the community themes for next year. So I, want to thank you for spending the year with us. There's so many hearts and souls that go into every single episode. So thank you to everybody behind the scene, especially our new editor-in-chief, the person that makes all of this sound and look good, Miss Mindy, who's a graduate student in speech pathology at Syracuse University, and is amazing and an avid runner, and we love her. So huzzah, Mindy, you did this on top of graduate school. I don't know how you're doing it, babe. We should pay you more and give you coffee. But yeah, thank you for being a part of First Bite. And I am totally going to enjoy January because I am like batch recording so many amazing episodes to release out over the next couple months. But we'll be back in February, and some really big, beautiful things are coming. So thank you for being a part of this community. May you build strong communities in your hometown, in your state. Yeah, thanks. So happy New Year. And to the ladies that are our guests today, God, I am so grateful that our stars crossed, and truly look forward to seeing the work that you do to place social determinants of health, population health, and public health strategically within our ASHA Big Nine. So thank you for being leaders. And y'all enjoy. All right, everybody, we have another episode brought to you by a bathroom because that's how the world works, and a great dress. But I feel like this is honestly the perfect way to end 2025, because we're going to have a crucial conversation to get us ready for a fresh 2026. And I am hoping that this new year brings more empathy for our fellow humans. And I really think we need to start empathy building by understanding viewpoints, needs, and the different lived experiences of our fellow humans. So I feel very passionately about that. And if y'all have ever tuned in, I'm sure you have heard that. But today's episode really is brought to you by my pelvic floor because I had to pee for like the millionth time when I was at Mississippi back in September. And I was making a beeline to the bathroom and I stopped because there was this beautiful woman in this amazing dress. And I had to stop and I don't even think I ever made it to the bathroom. But I don't think I did. No. But that's how I met Torrey because she had this breathtaking dress on. So, Torrey, this is how we met. And then you introduced me to Rachel and we had this lovely little conversation right there at the Mississippi State Conference. And that's what's beautiful about our profession is just having those moments of like getting to meet each other and then the magic happens. But Torrey, hi, let's start with you. Tell us, where was the dress from?
Well, yes. Well, thank you so much for bringing up the dress again. And I feel like I love meeting people and there's like shared things like that. But the dress is from Nordstrom Rack and we will get the link to the dress and link it somehow so people can see the dress. But yeah, so I'm so excited to be here today and have this discussion with both of you and the worldwide audience too. So my name is Torrey Robinson and I am a Mississippi native and I'm also a speech language pathologist, of course. But a lot of my work now, I'm a second year doctoral student in population health science. And I know the questions that I always get asked is like, what is population health? Or how did you get there? So that's why we're here today. But a little bit about me and my journey to being a speech language pathologist first. I grew up in a family of educators, and that's a lot of my reasoning and rationale for where I am today and all of my experiences. So, growing up in a family of educators, my mom, she was the primary educator in my household, even though all my family, they were educators as well, teachers, some type of capacity. So I was always in a school. I was always in a school, being the principal's child or the teacher's kid or something. I was always hanging around the school, or I would meet all these different teachers. They'd ask you how you doing, and you'll help out in the classroom like over summers. So I always got these different exposures, and no matter what school she was at. But really, the last school that she was at before she transitioned to another role, it was a kind of, I would say, like a high poverty school, Title I type school, and that school was really like a community school. And a lot of the things that she had to do when you think about going to school, children, you get an education, you're going to school to learn. But there were so many things that I was seeing when I was 12, 13, 14, 15, and I conceptualized those experiences today. And I'm like, whoa, this is exactly what I've been seeing and like what I'm learning in my program right now. So she would spend most of her time making sure children had food to go home with, yes. Working with community members, so like police departments and churches. So really using the school as like community. And then those experiences stuck with me. And then after that, figuring out what I wanted to do in my college life and everything, I knew that I did not want to be a teacher. I knew I didn't want to do that, but I loved education. Like I love children. I've always worked in daycares and did all these different things with children. So really how I became a speech language pathologist, and I went to church one day and this girl was like, oh, maybe you should try this program at Jackson State. And I went to Jackson State too. And I fell in love with speech language pathology because she told me about it. And I feel like I got everything that I was learning was being conceptualized. And I love the program. I love speech language pathology. And really, After I graduated with my master's, I did a fellowship, which is how I met Dr. Tyrone. She was my clinical supervisor at the time of the fellowship. But on this fellowship, I got a lot of interdisciplinary training or multidisciplinary training, and we did autism evaluation. So I got to learn the roles of psychologist, social work, early interventionist, occupational therapy, and just like this robust setting and really getting to talk about the patients that we're seeing and all these factors that affect them. And it was really a specialization in infant and early childhood, like behavioral health too. So then after that, I got all this training and I was like, oh, I don't know what I want to do next. And then the population health came up because Dr. Tyrone, she already got her doctorate in this. And I was like, oh, maybe I am interested in this. And then I started the program in fall 2024 and I fell in love with it. And all those experiences that I had, like being with my mom in the school district and my clinical experience at Jackson State, everything started coming together. Then I started realizing all of the disparities that I was seeing or differences in health. It's more than just the clinic, and health is in the school, health is in a church, health is in all these different places. And that's where I began to see that and conceptualize that. And now I'm learning the theory behind everything. So everything just came together. And it's really kind of a passion of mine because I'm very empathetic, and we talked about that kind of before we got started. Empathy is just like the core of kind of population health and how helping speech language pathologists and medical professionals, all these people, see beyond just this diagnosis. And we'll get into all these definitions more later, but that's kind of my story. And I feel like there's so many different parts to it, but that's the easiest way I could streamline it.
I honestly, I was destined to be empathetic. I'm a Pisces. Like, I didn't stand a chance. And then God help you when you're a Pisces and you're PMSing. Like, and then if Mercury goes askew, I mean, you're like, that's it, done. Put a fork in it. I'm going to be a teary eyed hot mess. But no, I just joke. But yeah, this is our patients, the clients, the humans that we serve are more than their diagnosis. And for frame of reference, folks, when we're recording this, because, we record a little in advance, we're in the middle of the government shutdown, and the states are starting to worry about funding for SNAP benefits. And they're worried about how are we going to feed our populations. And so that's the world as of today, Friday, October 24th, when we're recording. Dr. Rachel, how did you focus in this area?
Those things where the Lord just puts you in these places. And so there was a job open, and I have a good work ethic. I know I do. Sometimes I overcommit myself, but I do know I have a good work ethic. And she said that we have a job opening, but out of all the things that you've seen, what would you like to do? And I told her what I'd like to do. And she said, out of all these things, what would you not like to do? And I said, I don't want to do pediatric feeding. That looks really hard. And then she said, well, the job's pediatric feeding. I said, well, when can I start? Like, I will do it. And so that's how I got into pediatric feeding. Was I was not intending on doing that because I watched that outpatient. I'm like, that looks really hard. There's a lot of behavioral issues with that. And then, but then the job came open and I was like, okay, well, this is what's going to be. And I can look back and see how there was all of these different stepping stones of the journey that I've been on, this is what I was supposed to do. And so dive into pediatric feeding and swallowing, and loved it so much. Did that was all I did for the first couple of years. And then I always knew I wanted to go back and get a doctorate, because for multiple reasons. One reason was because no one else in my family has one. And so I would be a first generation doctoral person, whatever, hold a doctoral degree. And so I always knew I wanted to go back, but I didn't know when and in what. And I remember like senioritis, almost about to graduate with my master's, looking up PhD programs in speech pathology. And so flash forward, I'm working at UMC, and they had just opened up or the University of Mississippi Medical Center, and they had just opened up a brand new school. It was called the School of Population Health. And they were looking for some candidates. They were looking for some people to enroll. And so at the time, I didn't really know a whole lot about it. I just knew I was interested in health, and I was interested in like this bigger picture. I just did not have the words to know, like, there's these things that I'm seeing, but I'm like, there's got to be more. Like there's
Yeah.
something else that's happening here. That's that
Yeah.
connection. Like there were so many things. I'm like, this just makes sense. Like it was all just clicking in my mind, and I was starting to have like, oh well, this is why I'm seeing these speech and language delays. I mean, it could be because of this problem, but there's this pathway that it doesn't stop right here to here. It's just something else over here that's leading to down here.
It's all interconnected. And what's
Mm-hmm.
beautiful is that both of your stories start with education, start with exposure to our profession. And that's something that when we're looking at population health, when we're looking at public health, when we're looking at the term health, to me, that's all on a foundation of health literacy. Do we know about the world around us? And if, let's be honest, there's not that many SLPs in the grand scheme of things. So if you haven't met one or heard of one or had an exposure saturation rate, then you wouldn't know this is an opportunity to pursue professionally as a career or pursue for treatment across the life continuum. But
Mm-hmm.
Torrey, when you and I got to talk in there, and okay, so one, the hotel that Misha has her conference at is breathtaking. And they have this little alcove that's like glass and like modern feel and ever so chic. But we were sitting there in the alcove and you were telling me that you study population health. I heard public health. And you were like, wait, no, have you heard about population health? And I was like, no. So, what is the difference between population health versus public health?
That's actually such a great question. And it's just so good because a lot of times people, they're like, oh yeah, you're studying public health, but no, it's
No.
population health. It's two different things, but they complement each other in such a great way. So that's why it's so great. So, how I've been explaining population health versus public health, when we think about public health, we think about the broad scheme of things. Everybody benefits from it, all these communities, and you can think about COVID-19. And a great example I always use is hand washing. So, hand washing, it was invented by Dr. Semmelweis. I can't remember his first name, but his name's Dr. Semmelweis, and he invented hand washing because he saw people keep getting sick. So what's going on? Like, what is the cause of people getting sick? And then he invented hand washing. So that benefited everybody. Like everybody could wash their hands, and you could decrease these infections and all these things that were influenced by not washing your hands. But then when we think about population health, we can take it a step further and it's more detailed. So we may be looking at specific populations and in the public health space, but specific populations in the context of hand washing, we may look at, okay, why is this group not washing their hands compared to this other group? And what is preventing them from washing their hands? Do they not have hand soap? Do they not have clean water? What are these things that are impacting their ability to wash their hands that can influence their health outcomes later on? So public health is more so broad. And another way to think about it is COVID-19. Everybody experienced it, but everybody experienced the mask mandates and then vaccines. Vaccinations is a easy way to think about public health. Everybody benefits from that. But then with vaccinations, we may begin to look at compare different groups for different health outcomes. So why is this group of people not receiving vaccinations like this other group? Is it health literacy that impacts that? And how we perceive like the medical
Yeah.
healthcare system,
Yes.
those perceptions, and then also my own understanding of is this vaccine even healthy for me to take? So all these things make us think about population health. So it's really getting to the granular and like the nitty gritty of these health outcomes, while public health is ensuring this safety to everybody. Even though there's a research component there, is more so on a broader scheme. You can think about epidemiology, which is tracking these diseases, but population health gets to the bottom of why are these diseases occurring, and thinking about social determinants of health and all these different factors that can affect health outcomes.
And that's why she's a teaching assistant for the Essentials of Population Health class. That
Yeah,
was beautiful. I don't have anything else to add.
that was great. My thought was this explains to me why certain populations, and I'm just going to use Texas as an example because it made the national news this year,
Yes.
why there's measles outbreaks within certain populations. And it's because public health mandate is that you should get your MMR vaccine. And there's resources for this, but that particular population has a adherence to a certain faith, and they are not vaccinating their children, which caused the massive measles outbreak that happened. What was it, spring and summer 2025?
Yeah, it
Yep.
was.
And I would go so far as to venture a hypothesis that misinformation had been provided to this group about the safety of the vaccine and why we need the MMR vaccine. And children got sick. And unfortunately, I do believe one or two passed away, which is
Mhm.
heartbreaking from something that's preventable.
Yes.
Right. I mean, you hit the nail on the head. Like that's what population health, and that I think sometimes people just get really in the weeds of the word, I guess, population, because you think of
Yeah.
like the entire population. But you have to be, as population health scientists, we have to specify like what populations we're looking at. So like we then, with making decisions, we then decide, okay, this is the population I'm looking at. We're defining that. Like these are the two populations we're going to define what those are for us.
Mhm.
As that is your research interest that you're going to. So you may be looking at the entire population of the United States as compared to Canada or whatever it may be. But a lot of people, I think, just conflate that. When you hear population, you just think of everybody, when it's not necessarily everybody, but it's everybody in a group. Like it's everybody within a certain group characteristics that we're interested in. And then from there, better understanding how these structural, these social determinants are influencing these outcomes. And we also have additional sets of like tools and way our theories to better understand this as well too, but even looking at it from the life course and looking at it from what happens in utero, actually the mother's health before conception, but how all of these things can exist on a continue, how health exists on a continuum, but also can be influenced over across the life course, then shape these outcomes that we see later on.
I did catch something on the news this year. They were talking about Black maternal death rates in
Mm-hmm.
Mississippi, and how with the changes in access to prenatal care, the
Yeah.
closure of Planned Parenthoods, and removing of abortions, in some cases, those are medically necessary. And folks, I'm not going to go into the politics behind this, but please know I've had dear friends that have pursued them for personal reasons, and for maternal health, especially if it's a DNC and the little one passes. Um, but that population specifically has suffered greatly, and that's going to carry over to if the mama passes and then the baby
Exactly.
survives. Like, what is that family going to look like? I feel like there's an ace right there.
Yeah.
And we
Yeah.
know the more aces you have adverse childhood events, the more at need you are. It's just, folks, we got to take care of one another.
Mm-hmm.
Yeah. And I feel like that's what y'all are doing. I feel like that's the whole concept behind population health, is identifying how do we help one another.
Right. And it's
Yes.
understanding that it's not just, again, you'll hear me say this a lot during this time we have together, but it's not as simple as X equals Y. There's
Yeah.
all of these other things that are, it's not because I eat a Snicker bars and I have obesity. Like it's not that. It's these other factors at play that leads to this health outcome. And it's understanding that. And I think when we're able to understand that there's these other things going on, we can stop shaming an individual, I guess. Like it's not because of your own individual health behaviors, but that is the problem. Yes, you do have accountability. Like we all have accountability in our own individual actions, but there also are things that are exacerbating what we are able or not able to do, which can lead to health outcomes because of where we live, where we work, where we play. There's all of these other things that are added that can cause us to have stressors And there's biological consequences for living in chronic stress. And then that's why you're seeing some of these health outcomes that you have. And so we just want to encourage, as speech pathologists, Torrey and I, we've said this many times, like this is kind of our thing that we want to do. We like taking this show on the road and just educating other speech pathologists on why being aware of these other social determinants of health, just these structural things that are happening and how that can shape health outcomes, because we might not be able to fix it, but we might can help you put those referrals in place, or at least educate the caregiver of like, oh, okay, well, maybe you're here because you are having difficulties with your food and getting access to food. How can we refer you over or talk to your doctor for you about, hey, this is a problem our patient's seeing. Let's kind of help close the loop.
And that's just such a great point that Dr. Tyrone brought up. And when she mentioned that a lot of times we think about problems as like X and Y, like you do this, this will get better. But it's just so much more complex than that. And I think that's the thing about population health. Every question is complex. No question is just, we do this and things will be great. Everything has so many factors. And when she talked about the theories that we learned, there's this one theory that we may even reference again. We probably already referenced it, like this social ecological model in this theory. So when we think about, like you mentioned, the Black maternal health crisis and how in Mississippi we already have like maternity care deserts. So these mothers are not able to get to this prenatal care. But then also on the individual level, thinking about the model, there's an individual level component, which is your own knowledge and like your own health literacy. So, do you know about prenatal care? But then on this interpersonal level, your family, your friends, are people telling you about prenatal care and why it's beneficial, why you need to go there, and thinking about the health of your baby and what you're eating right now? And a lot of times, not having prenatal care puts you at risk for hypertension, gestational diabetes, and all these things that can exacerbate to mortality, unfortunately. Then when we walk up again, we look at the organizational level. So what are you a part of, even thinking about a school setting or a work setting? So these organizations, one person is a part of. Then the community. Do you have a supportive community? Do you have a church that has like diaper drives or community baby showers? Do you have people that are just there for you in your neighborhood? And thinking about all these things, then we get into the big part of everything, the policy level and these structural levels that influence everybody. And a great way to think about population health is that continuum. And also, I love this word because it's just such a great word. So ubiquitous. Everything, all these factors that are ubiquitous to us, which just means everybody is affected by it. Everybody gets the same thing. But all of these different structures that I talked about can influence how people are able to function in that. How are they able to survive? And when we think about the Black maternal health crisis, we have to be thinking about all these different levels that influence each other. And Dr. Tyrone also brought up a great point, and you did too, Ms. Michelle, just thinking about children and why it's so important to think about things in early life when we
Yes.
think about this model. And it's
Yeah.
not just black and white, it's not just this causes this. We have to think about all these structures that children come across because they don't just get up and say, okay, I'm going to my speech and language appointment and they have families. And that's another one of my interests, like social networks and the
Yeah.
importance of having a family that has the resources and has the knowledge to understand and know, oh, my child does need speech and language services or feeding therapy. But you have to be able to have these people around you to let you know that and tell you that. So it really goes back to it's a village. Like it takes a village to do these things.
I feel like we've lost so much of our village over the last couple of generations. Like
Yep.
my grandma raised me. I know how fortunate I was that she was there in the home. My other grandparents were next door. They were the keeper of the old wives' tales that were true. Like terrible truth. Anytime I got the croup when I was a kid, my grandma would take a spoonful of Vicks, dip it in sugar, pinch my nose, and make me eat it. And I remember we had the poison control lesson. I was probably in first grade, and Vicks has a do not digest like warning label. And I came home and I told grandma, you can't do that. And she goes, honey, I ain't killed you yet. I was like, but you could, because I learned you call this number for poison control. But, you know, that would not necessarily the best, but our village and our families, absolutely.
Right. And that, I mean, I know that's not necessarily the whole idea for this topic, but this is something that's of passion of Tori and I. But like that, if you just think about how humans, we're so meant to be connected, right? Like we're so meant to be among each other and to feel connection. And like back a long time ago, like what we would do is we lived intergenerational. You had children engaging in different aged play.
Yes.
And like
Yes.
the beauty of what that can do for everybody, because you not only have your life lessons that you learn from those who are older than you are, but you also have the support of helping out with your children. We're sharing each other's burdens, like what we're supposed to share each other's burdens. But when we're in isolation and by ourselves, because of how just the world has kind of moved towards, you start to lose that, and then that's stressful. Like I have the fortune of having my family, and both of my side, my family, my husband's family helps me with my child. I have no idea how you do that when you're by yourself. I work with
Pay a lot of
colleagues
graduate students to
yeah,
babysit every time
right.
they get sick, because we did this 2 states away from all our family for a really long. So to all of the lovely ladies who showed up and I fed you, thank you. Thank you a lot.
Thank you so much for being on that journey. But we require community, and then even so, that's like philosophical down in my heart. I believe that. But then even if you start to think about, so why are some populations engaging more in certain types of activities? Maybe it's involvement in things we do not think should be involved in. Well, is there a sense of community driving that? Maybe I don't have a sense of community at home because I don't have that at home. I don't really get that at school, but this group of people that I feel like I'm a part and I'm engaged and I'm worthy. So I'm going to engage with this group, but we might not be engaging in what is good behaviors that we would like to see per se. But a lot of it's just connection and longingness to be together. And that's why, even if you, I mean, that's at an individual level, but then if you just think about how can we map that and understand that? So Tori was talking about like social network analysis. That's a set of methods that you could use. But what you could do with that is you can map out, say, okay, all of these people here, these clusters of folks are in this one area. What is happening within those networks of which people are, and let's better describe those networks so we can understand the patterns of behaviors essentially. Um, but that's just something of that is very much so to me, just a mission of like, we just have to be in community and we just have to do this together. And especially in maternal mental health. I've done a podcast with one of our really lovely, she's a licensed clinical social worker, and she does a maternal health podcast. And we just talked together about locking arms and how important that is. And maybe we can even share her podcast. Like I didn't think about that till right now. Her name is LeJune Johnson.
I just wrote it down. What's the name of the
Yes,
podcast?
I'd have to go back and look. I will let you know, and we can
Okay.
link it too. But her name is LeJune Johnson, and she's a big advocate in maternal mental health as well too. But we have to lock arms with each other. And how can we lock arms with moms? I mean, dads are important too. We're not like discrediting dads, but like, how can we lock arms with moms? Because if we can have healthy moms, we can have healthy babies, and then we can have a healthy workforce. So whoever you're talking to, however you got to talk about to get the money for the funding, it doesn't matter. If we can make families strong, we can make the workforce strong for in the future.
Yes. Okay. So to that point, Tori, when we're working with pediatrics, why do we consider the role of the family, community, and policy level? Like, what factors are we looking out for? Like, I know what I'm looking for when I'm doing feeding therapy. Like, do we have access to food? Do we have access to formula? Do we have access to thickener if it's necessary, or a blender? Like, I'm looking for these. But I feel like that's micro, and maybe we need more macro level view. Teach me. Make me cool.
And I think you brought up a good point. Like the things that we're asking for to understand the resources, I think the strong foundation is developing that therapeutic alliance and that relationship with your families. And I think it does take building that trust to help them understand. So you're not just like, oh, do you have this or you don't have this? Really helping them and guiding them and meeting them where they are. And I think a big component of this and why we wanted to do this podcast and really talk about it is this upstreamist approach. So when we're thinking about upstream approach, you can think about a river. In the river, the upstream stuff is at the top of the river, but the downstream stuff, these little bitty factors that you don't see, like those individual level things, health behaviors, things that things that people do day in and out, bring utilizing speech language services or not utilizing them, or your own health behaviors, like even like healthy eating. Those are things that we can do every day in our health behaviors, but it's upstream stuff that causes this trickle down effect. Are there policies in place? Are there structures in place so you can get healthy foods for feeding therapy? Do you have the infrastructure in your neighborhood? Do you have parks where your child can go to socialize if there are goals in your plan of care that discuss, oh, social interaction, or they will imitate these words, or they'll play functional play, things that children need. And also when you're recommending, oh, do you have any books at home, or read this book with your child every day?
But do they have access to a book?
Do you have a
A
book? Do you
library?
have a book at your house? Do you have a library? Do you have a car to even get to that library, or all these things? So it seems like a lot to think about, but at the same time, we're all people. And I think that's a big part of it too, just recognizing that life is hard. And it's even hard for people that are high SES or middle SES, but everybody has different deficits in their life that they're trying to figure out. So our role as speech language pathologists is not to be the social worker or to be connecting, or I would say not to just be the social worker. That's not our role, but our role is just to be aware of these resources that you can just pin drop and namelessly drop.
Yeah.
Oh, this may be great for you if you want to do this. So we're not connecting them because we have to, but it's just things to be aware of to improve your speech and language outcomes, because you can't just be given all these recommendations all the time.
Yeah.
Then you know that there's issues at home. And I really want to disclose a story that made me think. I feel like I had a lot of stories that led me to this point of thinking about, okay, it's way more than um, imitating words. It's way more than that.
Yeah.
So I've had a family one time. If the child, I had a speech and language evaluation scheduled for this child, and sometimes like I may call and check in if they didn't confirm the appointment or something. And then this time, the day of the appointment, they didn't come. And I talked to the mom maybe like a week ago, and I was like, oh, like I wanted to come. So I checked in, and then the mom disclosed, oh, we had a robbery at our house, and the child saw the intruder. So just thinking about how it's way more than just your appointment. This child does not,
Yes.
this appointment is not this child's home. And like Dr. Tyrone was saying, children grow up in families that are in communities and are influenced by systems. So that's just this big point, and it's kind of like a wake up call. And you're like, oh, so what can I do? Like, what do I need to do? And we also have in our at UMC, our state hospital, we also have in a part of our department, there's also social needs clinic. So it's called
Mhm.
Evers Care, and it's the name is from Myrlie Evers. So Medgar Evers, the civil rights activist, his wife. So basically, this clinic is called the Myrlie Evers Institute for Elimination of Health Disparities. And what
Mm.
this clinic does, they have a food bank attached to it. So all these patients that go to the hospital are eligible
Yeah.
for these food bags that are handed out monthly. And one time I did have a patient that or I helped somebody to get them connected to this food bank, and it was a pediatric feeding patient,
Yeah.
and just to get them more exposure to different foods. So it's just being aware of these resources and understanding that until you have the food, the warmth, and everything you need, thinking about Maslow's hierarchy,
I was going to
it's
say that. Yes.
but it's so similar to social determinants of health. Like until you have the food, the warmth, the safety, all these things that you
Power
need,
running
there's
water.
no way that you're going to achieve all these long-term goals that you have on the plan of care for that child and that family. So you have to take a step back and understand. And also you'll see patterns in the outcomes of your sessions. If the same thing keeps happening, um, something else may be going on that may be preventing this carryover at home,
Yes.
or understanding how the family interacts with each other in their own attitudes and belief towards reading and being able to play with their child. So it's just so many things. I know that was a mouthful, but I feel like it's so, like I said, population health answers are so complex. So I just want to give a lot of description.
So my takeaway is that upstreaming is essentially predicated on our knowledge of interprofessional education, what our colleagues in different disciplines do, and then
Yes.
the act of transitioning from interprofessional education to interprofessional practice, which is like this. I
Yeah.
love IPE to IPP
Mhm.
because that's how well are we doing a handoff? How well are we collaborating? But on
Right.
that note, folks, findhelp.org is a website.
Yeah.
Findhelp.org. I've talked about it in other podcasts. I try to shout it out. I learned about this from Juliet Ochura, who's an SLP that worked at Boston Children's Hospital. I sat in on one of her lectures that she did. Heavens to Betsy's, probably like 5 or 6 years ago. It was spectacular. But you can put your zip code in and find area food banks. You can find resources to help pay your power bill, your propane bill, your housing support. Anything you could fathom, you can find at findhelp.org. Also, two additional points. One for the books, Dolly's Imagination Library. Dolly and her infinite wisdom. You can sign families up, they can sign up, and then Dolly Parton and her entity will mail a book a month. And it's according to developmental age. And that's like creating this big community. And then Dr. Brown's bottles, if you have families in needs, Dr. Brown's will ship bottles to a clinic or to a location at free cost. They won't send them directly to a family, but they'll send them to a clinic so that you can share. And then Dysphagia Outreach Project, which is in overdrive right now, but DOP. Thank you, Hillary, for all of your work. But DOP, if you need thickener, if you need formula, if you need a blender, an emulsifier, which I love. Have you ever worked with an emulsifier to make soup? Man, you just
Yeah. It's a very great stress reliever.
yes, it really
Very
is.
therapeutic to me.
If we make soup tonight, it's because mommy needs to blend something. But also, you were talking about if I eat a Snickers, I'm not obese, and I'm like, you know why I have this lovely little pooch here? Pizza movie wine night, come a Friday, but like
Uh-huh.
face her up. But I was like, her and I, she's still there, even despite my water aerobics, which is the greatest thing ever. If you haven't done, this is your get healthy trick. Find yourself a water aerobics class and get adopted by a bunch of 80-year-olds. It's my water aerobics instructor is my son's swim instructor, and she loves playing Ice Baby. But let me tell you what, the 82-year-old biddies in the class, when that song comes on, I'm like struggling to keep up. I'm like, yes, this is great.
That sounds like the best time. Like,
Yes. But
oh,
those were so many resources, but I couldn't let the opportunity go by when you were talking about. I was like, this is it. This is what we do to help support at the micro level, but connect them to the people upstream that can do
exactly.
the macro and keep working up. Oh, I love this.
Right. Well, another point to that too is just, so if we're even thinking about, this is where advocacy comes in, right?
Yes.
So how can we, as speech language pathologists, you may be in private practice where, or you might, whatever it might be, just, you're a speech language pathologist and your hands are tied. You can only do
So
so much.
much.
But you are doing so much though, because you're able to, like, let me conceptualize to kind of your point. Okay, so maybe our patient needs to be maybe in order to practice chewing, we want to do certain types of foods. But how can we think about, okay, mama, what's in your home right now? What
Yes.
do you have right now? And then tailoring it on to that, and then
Yes.
advancing through that based off of what we know they have, and then plugging them into resources if they have area food banks in their location. But another thing, like, and that's what I want to make sure that we just advocate for speech pathologists, is just engaging at that local level. So like if you want to make these higher, so as speech pathologists, how are we ever going to influence policy? It's going to be very hard in isolation,
Yes.
but it all starts with like local advocacy. So how
Yes.
can you engage in your area of which you vote and where you pay taxes, engage in just opportunities as they come up, to how can you educate just your local officials on some of these problems? How can you educate your state officials on some of these problems? And then from there, how can you educate your federal legislators about these problems that are happening? Because I think over the time we've forgotten the power of our voice, and
Yes.
the power of our voice. Like, you are a tax paying person, of which you have the right to talk to your legislator, and they want to hear from you. Like, they want to know
Yes.
what matters to their constituents. And so just saying, hey, I'm a speech language pathologist in my area. We don't have any access to food banks, but I see a lot of my families really very much so need this. These are the health outcomes when we don't have these things. What can you do to help me out? Because this is the people that are working, that you work for. So
Yes.
how can we just engage in local advocacy as well as beyond?
That's a whole big topic
Yep.
that is a little hot right now.
Right.
But I will put the onus back on us. This is why ASHA has a PAC.
Right.
ASHA has which is their political action committee, where they advocate, and they have lobbyists that they pay to advocate for our profession.
Mm-hmm.
Um, One of the things that bothers me is that Wake and Snap don't have a lot of celiac gluten-free options available. And that's worrisome because we, as a profession, anybody who works with individuals that need gluten-free options because of dietary restrictions, we should be advocating to have this. But those are federal decisions that trickle down to the state level. So if we're going to go upstream, are you a member of your state association? Are so that they can pay for a lobbyist to advocate for state level issues, and are you a member of ASHA PAC to help advocate for national level issues? Um, there was a bill that stalled in North Carolina probably a couple years ago that would have covered all enteral feeds. It made it mandatory that insurance pays for all enteral feeds. Um, and it stalled because of one Republican representative in North Carolina. But I'm talking for kids that have, yes, tube feeds for like general run of the mill Nutramigen or Elecare or real food blends, but also for, it's a condition. It begins with an L and I can't remember it, but it's like 42 to 7 grand a month for those particular formulas because of the complexity,
Right.
because their bodies can't digest carbohydrates or fats. And
Right.
then
Right.
without that formula, they die. But,
Right.
but advocacy.
Yeah,
Okay.
and that's real life issues, and so, like,
Yes.
that's the things that as speech pathologists, and that's kinda like to put a bow on why we're even, like, kinda to that point of talking about it, is because these things do directly impact us. These and that's a good example of that at that individual level, and then how there's things way up here that trickle down, and then that also trickle back up, though, too, as far for the good or for the bad, they come back
Yes.
and forth, and, like, that's really why we're kinda bringing it to this point of, it's because these things matter, and it's
Yes.
because the families that we are working with, may not have equal access to some of these resources. So how can we, one, be thoughtful of that, and then map our plans of care accordingly, our therapeutic plans, our therapeutic goals according to what we know our families have, but then know that it is important, and it's important that we engage in just advocating, because again, these things, what happens, it does directly affect us. So
Yes.
Thank you for kind of tying us up on that part.
Yes, but that gets us back over to social determinants of health. So, Torrey, can you talk to us about, like, I know we're talking and rattling around it, but like, get us there, please.
Yeah. Yeah, I feel like we talked about it like the whole time with bits and pieces, but just what social determinants of health are, and it's just these non-medical factors that influence health outcomes. So it's thinking beyond just the medical diagnosis and looking at education, so socioeconomic status, then looking at physical environment. Physical environment just means the neighborhood and neighborhood safety and neighborhood amenities too.
Yeah.
And then also looking at social and community context. So that idea that we were talking about, social networks and social cohesion. So do you have these people even around you to help you with your health? And then also looking at Dr. Tyrone, if I'm missing one, just help me. And then also I am missing one. So help me out.
So there's different, it depends upon which kind of framework you want to look at, right? So the World Health Organization has a set of what they term social terms of health, and then Healthy People 2030, they have like a couple buckets of what they consider social determinants of health, and they can all kind of be merged into a lot of the same similar things. This is not necessarily because what Tori is discussing, she's talking about the Healthy People 2030 version of what that looks like. And so I would mean I was paying attention, but I don't quite recall which one you missed on there. But one thing I would add to that is early life experience, and why that is an important social terms of health too. You covered just the built environment. Yes.
Healthy People
And
2030.
then I remembered it now. And then healthcare access. So,
Yeah.
and the thing about the social determinants of health, and when we look at the percentages, it's like 80% of your health is influenced by the social, physical, and socioeconomic status factors, and only 20% of our health, 10 to 20%, made from healthcare access. So just being able to go to a doctor's appointment, being able to just have healthcare and have insurance influence only a little bit. But it's just all this back and forth between the two. So that 80% that I was talking about influences the healthcare access. Then healthcare access influences all the other things. So the social determinants of health is just this great framework to just look at and think about. And then a big component that I mentioned, education, but I think the spectrum between the two, and a good thing to think about population health, is this continuum. So even having healthcare access or having education access, what is the quality of that? So are you actually getting the healthcare that you need in your interactions? And that gets into this idea of implicit bias and all these things that you can encounter in the healthcare system. And I think that's a big reason Dr. Tyrone and I are wanting to educate people more, because when you really don't understand about social determinants of health and understand these factors, that everybody has implicit bias, but that can influence how you think about things and conceptualize things. So it's kind of like checking yourself to see, okay, is this the reason this person is not coming to the appointment? Is it because they just don't want to come, or is it because Medicaid transportation or some type of transportation is not working for them, that they miss their appointment? And it's not just because they don't want to come. And also, when Dr. Tyrone was talking about maternal mental health too, that's a big component of thinking about that social and community context of our families and what we see, does this mother have this social support to get beyond this diagnosis of depression? Is there somebody there to support them? And if you're asking them, oh, what do you do at home? What are fun things you like to do? And the mother may have like a flat affect. So that's not something to take to heart. It's just something to understand. Okay, there may be something else going on that may be preventing these positive interactions and with their child, smiling, laughing, and all these things. So I think that's just social determinants help this help us have this foundation of things to rely on, so we can get past this implicit bias and all these things that can influence these poor and negative health outcomes.
I don't know if y'all know this, maybe y'all do, but Asha even has a whole like page about social determinants of health and covers exactly what it was that Tori was talking about, and even discusses kind of our role within social
Yes.
determinants of health. I don't know. I need to do some investigating to find out when they first like let that go live or put that live, because I'm very excited that our own association is recognizing that these things are important,
Yes.
because they are directly important. And so what you'll see on the website there, you can go to either one of those resources for to better understand what social determinants of health are, because it's not just like a list of these specific variables per se. There are some, but it's just a lot of different pieces that influence health outcomes and that can be shaped by those the things, the areas of which we work, where we live, where we play.
Yes.
But I do highly encourage you to go and check those out, because I'm super excited that ASHA is on support of us better understanding social determinants of health. And so now from there, we just have to get into our training programs to where our training programs can also incorporate this as far as an understanding of what are social determinants of health too. That's where me and Tori are trying to come in to play. We want to go to all the training programs.
Yes, but like embed it within each of the core classes,
Right.
because that's to get to Tori's comment about our bias in medicine, our bias in the profession. Like, I look back at my career and think painfully, because of anxiety, of like how I've said and behaved and what I've done. And I'm like, oh, well, I screwed that up royally. There was a bias there. That was like something I didn't know in the moment, but in retrospect, the more that I know, I picked up on it. So, for example, not realizing and making assumptions about the food that was being offered, making assumptions about one drink being inferior or superior to another beverage that may be offered, or assuming that they're not following through with the recommendations that I'm given
Right.
because they don't like it, but not understanding that the recommendation for carryover that I gave does not adhere to that cultural practice. I worked with a family that was Indian, and their caste, I'm not sure how to,
Okay.
I think it's caste, but they didn't hold the cup to their lips because they were higher born, but the child needed to work on cup drinking. And so I was
Right.
like, just place it right here and work on lip rounding. But I didn't know that that was the inappropriate advice because of their, and I just assumed that they were being contrary and I didn't know. And then as soon as I learned, I was like, well, health bells, I should ask first. You are 1000%. It's got to be embedded in every single class. Tie this in, okay, for feeding, for swallowing, for fluency, for understanding the cultural changes around fluency. And how different cultures perceive that, but that carries over to access to care, because that would be what you were saying, the community, your intrapersonal relationships, like it all builds on it. And if we look at our profession, that's predominantly white women. We don't represent those that we serve.
Mm-hmm.
And you brought up, that's a great point, leading into like representation. And I want to applaud you because the important thing about like our talking, what we're saying, like reflection is so powerful. And if you go back and like you cringe or that's a good thing,
Thank you. I'm
because
like,
you know that because you know that you when you know better, you do better. And that's
yeah,
how it should be. Like we shouldn't be stuck in these same practices of thinking when we know it's not fixing the problem. But to your point about representation, I think that's just such a big part of being in this field, and how
yes,
in even in like my high school like life, even what we talked about earlier about the exposure to speech language pathology,
yes,
there's even disparities there, because I did not know about speech language pathology until um somebody until like way further, like in my, I think mid like community college, like I didn't know about that until then. And the way that some people know about it and are planned out way before that, and we only, in Black and African American people, we only make up 3.6% of the field. I think that number is getting higher, but it's just the importance of representation and the amount of times that I've worked with families and they are so relieved and kind of happy to have a Black speech language pathologist after, having a traditional white speech language pathologist. And it's just that power of connection and being able to understand some of the experience that they've had, but just sometimes how it is just a great thing to have this representation in anything. And
yes,
it just reminds me of a big thing that just happened, like Misty Copeland and ballerina. Like
yes,
she's the first Black ballerina, but nobody would have known about being in the ballet, little Black girl, until she was in the ballet. And that's just a great scenario that I thought to bring up. But she closed her performance and it was great. But the power of representation truly does matter.
Yes. Okay, so folks, on that note, because I do have to wrap us up, ladies. We will pull the show notes, and I wrote a list of things that we'll add to the show notes. So the Healthy People 2030, the WHO, and the ASHA Social Determinants of Health resources. We'll get the information for the maternal health podcast that y'all were referencing. It would be great if y'all could send some maybe a journal link or two where we can like access and like support would be wonderful. Including any publications that y'all have would be amazing. But if folks want to learn more from y'all, is there an email address or a way that they could reach out to y'all respectfully?
Yes.
yeah. Do you just want us to send that and you can drop them at the
If you
bottom?
could say it out loud as
Okay.
well.
So I would be more than happy to take any emails for any questions that people have. I am RTYRONE at umc.edu. So just R Tyrone at umc.edu.
And I am T.R. Robinson at umc.edu. And also Torrey Robinson. I think Dr. Tyrone and I, we're both on LinkedIn too. So you can find us that way, which may be easier to connect to, because sometimes emails are hard, but a lot of people are on LinkedIn too. So
Yes.
I don't check mine quite as well, but feel free to get to Tori will check hers. I'm on a social media hiatus to an extent. So
Honestly, I understand because I do the social media for the podcast, and good Lord, I am old and feeling the 42.
yeah. Yeah.
So,
You can ask Tori. It's painful sometimes when she's in my office and she's telling me, click this. And I'm like, where is it? It's getting painful.
yes. Now, and then the last question is if somebody has any mad money or little love money laying around, what organization or entity could they donate to?
So, Tori, I was thinking about it as we were talking, and you were talking about Evers Care, and I don't know necessarily how much they allow for like monetary donations, but I know their food bank could always use more supplies. So, if you want to look up, and we'll give a link because I don't know the exact link to get there, but if you want to look up there and see how you can drop off some food, especially if you're in the Mississippi area, we would love for you to be able to do that because it is located in Mississippi. But we'll get a little bit of some more information to Michelle, and you can drop it in the notes as far as how we could provide some foods to go to the food bank, because that food bank, every time they fill up lots of cars and it's always gone. So it is a very great resource for the community and for the patients that our large medical center serves. So we would love, if there's any way at all to help support the food bank, we would love that.
Yeah, and right now they're in need of donations. So, like we said, we'll try to see if there's like an easy way people can do that internationally or nationally, or if they can accept monetary donations.
That'd be amazing. Yes. Well, I am so grateful for Nordstrom Rack. And for that fabulous dress that you like crushed it, and my forever pelvic floor therapy bathroom break. But I know that was all the good Lord lining all that up. But with a very, very full heart, thank y'all for closing out 2025 with a focus on humanity. I am hoping 2026 takes this to heart, and that we do better by one another.
Thank you all. Thank you all for having us, and let's just love each other.